Thank you for joining us today. We'll just give people maybe one more minute and then we will start our webinar. Good afternoon and welcome to this week's Wednesday webinar. My name is Fiona Robinson and I am the series host. The title of today's webinar is Research in Children and Adolescents with Inherited Bleeding Disorders. This webinar is being recorded and the recording will be available shortly after it ends on the National Bleeding Disorders Federation website, bleeding.org. We encourage you to ask any questions you may have today. You can ask your question by entering it in the Q&A feature at the bottom of your screen. You can put that in there at any time during the webinar and we'll keep an eye out for them. And then when our speakers have finished their presentations, we'll put your questions to them. This webinar is the second in a special Research Journal Club series. This is a collaboration between the National Bleeding Disorders Foundation, or NBDF, and the Hemostasis and Thrombosis Research Society, or HTRS. We are very fortunate to have Dr. Michael Recht, Chief Medical and Scientific Officer at NBDF, with us today to say a few words of welcome and introduction.
Thanks so much, Fiona, and thank you everybody for joining today's webinar. As Fiona said, my name is Mike Recht. I'm a pediatric hematologist and the Chief Medical and Scientific Officer at the National Bleeding Disorders Foundation. As most of you know, National Bleeding Disorders Foundation is dedicated to finding cures for inheritable blood and bleeding disorders and addressing and preventing the complication of these disorders through research and education and advocacy. In 2025, we have partnered with the Hemostasis and Thrombosis Research Society, or HTRS, for the 2025 Research Journal Club, which is a series of webinars highlighting emerging real-world research in the bleeding disorders community. HTRS is the leading North American professional society dedicated to research and mentoring and workforce development and continuing medical education for physicians and investigators and all healthcare professionals interested in advancing care for people with hemostatic and thrombotic disorders. Today's speakers are top notch. I'm so excited to hear what they're going to talk to us about. Both Dr. Lauren Amos and Dr. Sharon Carpenter are faculty members at Children's Mercy Hospital in Kansas City, Missouri. Lauren is the director of the Pediatric Hematology Oncology Fellowship at Children's Mercy and is part of the Hemophilia Treatment Center there. I've known Shannon for probably 20 plus years. We've collaborated on various projects. Her research focuses on bleeding and clotting disorders. She also works at the Comprehensive Hemophilia Treatment Center at Children's Mercy, and as of April is now the division head of pediatric hematology, oncology, and bone marrow transplant at Children's Mercy. We are also very excited to be joined today by Sadina Hartley. Sadina will be representing the lived experience expert point of view on today's webinar. She has a 10-year-old son with hemophilia A. So, speakers, take off. Looking forward to hearing you.
All right, can everyone see that?
We see it, but it's still in working mode if you want to pop into presentation mode.
I just switched over, so let me know.
Okay. For the moment, we still have the working view. If you want to go ahead and present like that, you can. Otherwise, you can try ending the sharing, going to presentation mode, and then going back to sharing.
Can you see it now?
We see it. It's still in the working mode, but that's fine. It works. We can see it well.
Yeah, I don't know. It worked before.
Sometimes Zoom is unhelpful.
Okay, well, for the sake of time, I'll leave it in this just so I don't take too much time up. But as Dr. Rex said, I'm Lauren Emis. I'm a pediatric hematologist at Children's Mercy and very excited for this opportunity today to um, present the latest evidence on an area that I am very passionate about and excited for this journal club today. So, I'm going to discuss the current state of treatment of heavy menstrual bleeding in adolescents with bleeding disorders. I'm going to start with some background regarding this topic. I'll then review our current treatment options and then move on to some hot topics that are currently areas of research that are expanding and need further work. So, these include combination hormonal therapy with the use of an antifibrinolytic like tranexamic acid, and then also iron deficiency due to heavy menstrual bleeding in the bleeding disorder population. And lastly, I'll focus on the unmet research needs for this population. So, to start with some background, heavy menstrual bleeding is common in adolescents. It has an approximate prevalence of 37%. About 20% of these patients who present in the outpatient setting will be diagnosed with an underlying bleeding disorder. And about 33% of adolescents who are hospitalized for heavy menstrual bleeding will ultimately also be diagnosed with a bleeding disorder. So, this is a large population that needs more treatment options. Heavy menstrual bleeding disproportionately affects adolescents with inherited bleeding disorders, unfortunately. There's increased morbidity. This includes missed school, activity, work days, and also decreased quality of life with increased rates of depression and anxiety. So, unfortunately, there is no standard consensus recommendation for first line therapy for adolescents and young adults with bleeding disorders and heavy menstrual bleeding. There are a variety of treatment options that exist. These include the use of hormonal therapy, such as combination hormonal contraceptives or CHCs, or use of progesterone only. And then there's hemostatic therapy like factor products, desmopressin, and antifibrinolytics like tranexamic acid. Intrauterine therapy also exists in the form of intrauterine devices. And then there's the use of combination therapy, so hormonal plus hemostatic therapy. As I'm going to review with you, the evidence is still very lacking in terms of treatment for adolescents with bleeding disorders and heavy menstrual bleeding. The most recent Cochrane review to look at this population looked at women with bleeding disorders and heavy menstrual bleeding, and this was in 2016. And unfortunately, none of those studies that were included of the 3 randomized controlled trials included hormonal therapy, which is often a first line therapy. There was a 10-year retrospective study conducted at our institution by Dr. Carpenter and colleagues. In this, 53% of patients who were adolescents with bleeding disorders failed initial treatment for heavy menstrual bleeding, and that most of the time occurred with combination hormonal contraceptives. We then looked specifically at patients with platelet function disorders, and 55% or over half failed first line single agent treatment with hormonal therapy. So there's a large failure rate, even when initial therapy includes hormonal treatment. So, in terms of second line therapy, treating physicians will often move to combination hormonal therapy plus tranexamic acid. Yet safety concerns regarding theoretical thrombotic risk exist, and there's unfortunately a black box warning in the United States due to a potential risk of a thromboembolic event if you use estrogen plus tranexamic acid. However, there have been no documented thromboembolic events in females with bleeding disorders who use combination oral contraceptives and tranexamic acid. So Thorne and colleagues conducted a database search using Medline, PubMed, and Embase in 2018. They searched for tranexamic acid, oral contraceptive, and heavy menstrual bleeding. They looked at publications from 1976 to 2017, and there were no studies that directly addressed the use of tranexamic acid with combined hormonal contraceptives. And they found one case report using these combination therapy in an older female patient with a coronary vessel thrombosis, which ultimately was not able to be attributed to the use of this combination therapy. So, further research looking at the use of these two modalities, Epstein and colleagues did a retrospective review of hormonal therapy and tranexamic acid in the United Kingdom. They included 142 women with bleeding disorders. The age range was 10 to 54 years, so did include the adolescent population. There were no women with family or personal history of venous thromboembolism. 37 or 26% of the population who used these medicines were overweight or obese, which is important to note as there was concern about using estrogen and tranexamic acid in a population that is overweight or obese just because of the increased risk of thrombosis. In this retrospective review, 89% of the subjects included rated combination therapy as effective. And important to note, there was no VT reported. And then Alakazam and colleagues looked at 34 adolescent patients who were referred for heavy menstrual bleeding and then ultimately were diagnosed with a bleeding disorder. So this was a specific study looking at bleeding disorder patients who use these medicines. 24 were treated with combination hormonal contraceptives alone. And similar to the rates out of our institution, 58% or more than half failed that therapy. They did not look at tranexamic acid use alone or monotherapy, but they did have a small number, 13 patients who were treated with tranexamic acid and combination hormonal contraceptives. And in this very small cohort, 100% achieved menstrual suppression, which was statistically significant. So then I recently presented at ASH in 2024 a multi-center retrospective study to evaluate the use of combination hormonal therapy plus tranexamic acid. And in our study, there were 221 patients included who had inherited bleeding disorders and heavy menstrual bleeding. And as you can tell, of the 221 patients, there was a large amount of treatment modalities trialed, so 474 different treatment regimens. The most common was combination estrogen and progesterone, followed by the use of progesterone or TXA alone. And the use of hormonal therapy plus TXA was extremely small, even in our cohort. But when we looked at efficacy for these regimens, when we saw if the subjects rated heavy menstrual bleeding control as being achieved as yes, in the combination hormonal therapy group, there was 71%. But if you look at our hormonal therapy rates with tranexamic acid, they had very high ratings of efficacy and control of heavy menstrual bleeding at 90% for estrogen and progesterone plus TXA and 92% for progesterone plus TXA. And this predicted an odds ratio that if you used hormonal therapy, so this could be combination hormonal contraceptives plus TXA or progesterone plus TXA, you were 3.62 times more likely to achieve control of heavy menstrual bleeding versus the other treatment modalities alone. So next, I want to look at another second-line therapy that's showing promising efficacy in adolescents with heavy menstrual bleeding, and that's the levonorgestrel IUD. So Kendall and colleagues did a retrospective multi-center cohort from February 2014 to 2020. They had 43 adolescents with bleeding disorders and 35 without who underwent placement of an IUD for heavy menstrual bleeding. The mean age at time of presentation for these patients was 14.9 years, but range was 11 to 21. And the mean age at IUD placement was 15.8. 90% of these bleeding disorder patients had failed other modalities to treat heavy menstrual bleeding, although the study did not report any patients as using combination hormonal therapy plus tranexamic acid. There was breakthrough bleeding, which occurred, which is a known side effect of the IUD initially. That occurred in 53% with bleeding disorders versus 49% with no bleeding disorders. So there was no statistical difference in the population. And in terms of IUD event in the bleeding disorder patients, 16% experienced malposition, 5 or 12% experienced expulsion, and one patient required removal request. So this is obviously a very small a study sample, but showing that the rates of adverse events were similar between bleeding disorder and non-bleeding disorder patients. Next, I'll move to a systematic review and meta-analysis in women with bleeding disorders who use the levonorgestrel IUD. This was a PubMed, Embase, and Cochrane database search with 583 results. They only were able to include 6 observational studies, and that was 506 156 subjects. The levonorgestrel IUD was associated with amenorrhea in 60% of patients. You saw the increase of hemoglobin in these patients of over a gram and almost 20 in their ferritin, so improvement in iron deficiency and anemia. After treatment, the hemoglobin was normal at 13 with a normal ferritin of 43. There were low expulsion rates at 13%, and removal due to lack of efficacy was also low in this database results at 14%. So I think something important to note when we're thinking about adolescents and IUDs is caregiver concerns. So Juho and colleagues looked at this specific subject by conducting a survey of caregivers for adolescents and young adults with heavy menstrual bleeding to assess knowledge and attitudes towards IUDs. And they surveyed pediatric gynecologists, hematologists, and adolescent medicine offices. Unfortunately, they only had 40 surveys completed, which we know is a problem with survey research. But 70% of the respondents said that they would allow their child to use combination hormonal therapy for heavy menstrual bleeding, yet only 10% said the same for IUDs, although the mean knowledge score of that group was high at 73%. So it didn't seem to be due to a lack of knowledge regarding IUDs. However, these caregivers did want more information. 65% wanted more information about IUDs, highlighting that caregivers of adolescents with heavy menstrual bleeding may need more education to consider this efficacious route. I next want to move on quickly to iron deficiency because this is also a very important issue that goes along with heavy menstrual bleeding in our bleeding disorder population. Iron deficiency is common but under-recognized, and it also causes numerous adverse effects on adolescents and young adults. So there's a physical impact in terms of decreased exercise tolerance, fatigue, dizziness, poor sleep quality, hair loss, and the list goes on really. And these are all really detrimental at a crucial time in development and growth for adolescents. And then also mental health impact due to these physical impact and fatigue and not being able to really achieve the goals that these patients have. Iron deficiency symptoms result in 1/3 of women missing school or work, and we know that heavy menstrual bleeding greatly increases the risk of iron deficiency. So looking at iron deficiency due to heavy menstrual bleeding, up to 87.5% of adolescents with heavy menstrual bleeding have iron deficiency as defined by a serum ferritin less than 40. The American College of Gynecology recommends all adolescents with heavy menstrual bleeding should be screened for iron deficiency. Yet screening rates are as low as 10% in this population. And there are no screening recommendations for adolescents and young adults with bleeding disorders, even though the rates of heavy menstrual bleeding might be as high as 80%. So when we look at the limited research that exists about heavy menstrual bleeding in the bleeding disorder population, McCormick and colleagues conducted a survey of the Hemophilia Treatment Center providers and collected retrospective data from the American Thrombosis and Hemostasis Network, or ATHEN data set, from 2015 to 2019. They had 142 HTCs and 62 responses to the survey. And then the data pulled from the ATHEN data set were females 13 to 40 years of age receiving care at an ATHEN affiliated HTC. And this resulted in 10,527 unique female participants. When we look at the survey results, you're going to see a variation in what practice patterns occur. So when asked, when do you screen for iron deficiency in females with bleeding disorders, 69% they said that they screened routinely. 32% they said they screened only if they had heavy menstrual bleeding or other bleeding symptoms. About 10% said they screened only in symptomatic patients, and about 4.8% said only in patients with anemia. And then there was some variety in which tests were used to screen, although 98% did use ferritin as screening. And then in terms of when did they repeat labs to check for iron replacement, there was also a wide range here with 43% checking it a month, up to 75% saying that they checked at 3 months. In terms of the data set results that were obtained, 374 subjects had test results for iron deficiency, so a very low number of the study population. And that included a transferrin, total iron binding capacity, percent saturation, or a ferritin. Of those screened, though, and reported in the database, 71% had iron deficiency. And then in terms of change in practice over the study period, there was not a significant increase. It went from 1.27% to 2.92% of the study period. 741 participants had any of the following labs. So that was a transferrin, a TIBC, percent SAT, ferritin, MCV, or hemoglobin. And of those, 64% had iron deficiency. There were hemoglobins available for 515 subjects, and of those, 30% had anemia. And then of those who had hemoglobin results, 71% had iron deficiency anemia recorded. So, in terms of takeaway points from the evidence that I've reviewed today, I want to highlight that despite high prevalence of heavy menstrual bleeding in adolescents and young adults with bleeding disorders, there's high rates of first-line treatment failure, and we really have limited data on the efficacy and safety of second-line treatments. But there are promising small studies that show increased efficacy and safety of combination hormonal therapy plus tranexamic acid and the levonorgestrel IUD in this population. However, we really need larger studies to establish standard of care and treatment guidelines in this vulnerable population to limit the failure of first-line therapy and decrease the comorbidities that are caused. These patients also have high rates of iron deficiency and iron deficiency anemia, yet data in this population is very scarce. There's a significant variation in HTC providers regarding screening and monitoring and treatment outcomes. And despite a high rate of screening, the data regarding screening results is still limited in the Athens data set. So we need enhanced screening guidelines, treatment recommendations, and outcomes data for this population. And here are my references. I appreciate everyone sticking with the technological difficulties of today. And once again, I'm thankful for the opportunity to talk about these really important issues in our adolescent and young adult population.
I think, Fiona, you just want me to take over from here and I'll just go from there.
Yes, please.
Okay, off I go. Let me know when you see what you want to see.
All right, we've got you in your working mode.
Oh, there we go. I'm pushing the button.
Perfect.
It's ignoring me. Okay, can you guys see everything now?
Yep.
All right. So what this is going to transpire, though, is that my camera is here and my screen is here. So I will not be looking at you when I do this. I just want you to know that. But I'm not. I just wanted to let the audience know that that's what's happening. I'm going to talk a little bit about the novel therapies for hemophilia and bleeding disorders and other bleeding disorders. And I'm going to take a different twist on things. There are a lot of things I wanted to talk about, but I only have 20 minutes, so I will limit my commentary. So our objectives today are to outline why some novel therapies are being pursued, describe the areas of coagulation cascade being targeted, and that does require me to show you the coagulation cascade, discuss evidence for recently improved novel therapies, and discuss novel agents under investigation and some evidence about them to date. I cannot cover all of this. And so because of that, I'm not going to cover gene therapy. That could be its own space. So we're gonna talk about other things other than gene therapy, and also do some unanswered questions regarding these therapies and what we need to do differently. Think about. So why would we need new products? Our factor products are actually excellent, and they provide great hemostatic control across most of our patient population. However, it is intravenous administration and multiple doses per week, or in many cases, though our extended half-life certainly have helped with that, leading to weekly dosing or even every other weekly dosing, depending upon the disorder and the drug itself. But factor supplies are inadequate in some countries, and so we have to continue to be a little bit creative about handling the worldwide problem of hemophilia and other bleeding disorders. 20 to 30% of severe hemophilia A patients develop inhibitors to their factor replacement product. And so traditionally, we've used bypassing agents, intravenous bypassing agents, and the burden of that care has been pretty significant, either with multiple injections per day or per week, and long infusion times. And the hemostasis has been, good, but maybe not perfect with those medications. Many rare bleeding disorders do not have a specific factor product available to them. Certainly, we've done better with that. And I'm not going to go into a lot of those factor replacement products, but there are opportunities to exploit some of the other parts of the coagulation cascade that will help us to explore new treatment strategies. And pretty much for all of those other factor replacement products, there also continue to be intravenous. So the pattern of treatment for hemophilia and von Willebrand disease and advances has been a story of periods of plateauing and then periods of growth. And if you look at this timeline from Zhang et al., which was recently published, you can see some pretty big time points that are important to the history of both of these disorders. First off, figuring out what these disorders were. You can see Dr. Otto and Dr. von Willebrand, their reports in those time periods in the last 2 centuries. And then within the 50s and 60s, there was some advancement, certainly Judith Graham Poole with the development of cryoprecipitate. But then in the 80s with the AIDS epidemic, there was a real drive with that to develop recombinant treatment to provide safety for our patient population. And so within that decade, a lot happened beyond that, both good and bad. But then there was a plateau period from the 90s to really the early 2000s, about a 20-year, 25-year plateau period where there were some advances in hemophilia and bleeding disorder treatment. But overall, there was a lot of satisfaction with what we had. There were minor improvements in treatment. But overall, until the extended half-life concentrates began to be developed in mid-2000 teens, we didn't see much else. And then along that time, we saw the factor VIII mimetic bispecific antibody, and we'll talk a little bit about what's happened with that. And then, of course, the advent of the TFPI antibodies and gene therapy. So this is my contractually obligated coagulation cascade, but I want to point out a few things about this. Walking some of you who may not be familiar with this through this, we have our intrinsic pathway, which is where factor VIII and IX live. And that's going to be your PTT if you're doing a screening test that's prolonged. And our extrinsic pathway, which is where factor VII lives, and that's your PT. And then these combine at factor 10, and this is the very simplified version of the coagulation cascade. But ultimately, what we're trying to do with all of this is to have thrombin generation. And so how can we generate thrombin and do it in a strong enough way to create a clot? And so you'll see a few highlighted red words there. And these are targets that have been developed to utilize the coagulation cascade in a slightly different way. So these are inhibitors of coagulation. And if we block these inhibitors of coagulation, could we then make the coagulation, even a weaker coagulation, work better and generate more thrombin? And the answer to that question is yes. So this was not doing that. This was a factor VIII mimetic, and everybody's, I think, at this point familiar with emicizumab. At this point, it's been on the market for a number of years, and it is a bispecific antibody to factor IX and factor 10. I always liked the old name for it, which was ACE910, because you could really tell what it did. But it takes the place of factor VIII in coagulation, a once weekly to every 4-week subcutaneous injection. Oh, whoops, that's an old slide. Phase 3 trial has been out for a while. But we recently did a study that used some post hoc analysis of the Haven 4 trial. Haven 7 trial. And we looked at the infants who had the bleeding and what the bleeding patterns were for infants on that trial. And what we found was that no intracranial hemorrhage occurred in these infants who were on this trial. And I've left out a few of the slides just for the interest of time. And that the bleed types were primarily on the head, so nose and mouth primarily. But prior to study entry, most have been in the lower extremities. And all of that is very good hemostasis, and we do appreciate that. And you can see these cute little cartoons that have where the bleeds are and what proportions are there. But what I want to point out particularly is that what we found with this post-hoc analysis is that bleeding patterns were similar to bruising and injury patterns in infants without hemophilia. And this has been presented at a couple of different meetings, most recently at the American Society of Pediatric Hematology Oncology, but various other meetings that we presented this data. And the majority of the bleeds were observed in infants and children aged greater than 56 weeks, so over a year of age, and mirrored their mobility. And so as they started to move around, they had more bruising and bleeding. But the amount of bruising and bleeding that they had was actually very similar in pattern and amount to normal infants. And so that was fascinating. And there's been some good studies here by Kemp and Collins. You'll see at the bottom right of this study, of this slide, that looked at normal infants and then those with bleeding disorders and looked at the different types of bleeding patterns. So again, these bleeds on the head were not intracranial, but we do see that kids have big heads and fall over, I think is what we find with this information, but mostly nose and mouth bleeds. So there have been advances in further factor VIII mimetics. The mimate or mimate, I'm never quite sure, but it is an IgG4 bispecific antibody with a monovalent factor IX arm. And it can be weekly or monthly prophylaxis. And there were some phase 3 interim clinical trial results that were reported at ASH 2024, which were excellent. And then on the horizon, we have Next 007, which is the imicizumab heavy chains combined with a new light chains, which leads to enhanced activity. And it is also subcutaneous. And then the INO8, which is a factor VIII mimetic bidomain antibody, which is really small. And because of that, it can be taken orally with this absorption enhancer, which I love, is called SNAC, SNAC. I want to go back to the mimic just for a second. In that trial, what they found was that it had a little bit less in solution factor IX activity. And so one of the things that have been concerning with initial treatment with imicizumab on the earlier trials was that the thrombotic risk. And so there's theoretically less thrombotic risk, though that thrombotic risk was mitigated by not utilizing FIBA instead of using lower dosing. So moving on to other parts of the coagulation cascade, we have our fitusiran, or Qfitlia is the brand name. And this is RNA interference. And so again, now we're taking our antithrombin and we're blocking antithrombin so the body makes less of it. And so in doing so, you take down that and you get more thrombin, okay? And that should lead to more clotting. So subcutaneous administration monthly, indication for both hemophilia A and B, but maybe other disorders were not, could potentially be an option. In one of the original studies shown with this, you can see that the healthy volunteers have this thrombin generation. So the y-axis is how much thrombin you're making, which is our clotter. And then the x-axis is the antithrombin level. And the closer you get to a lower antithrombin level in our hemophilia patients, the closer you get to the thrombin generation that you were looking for that's more closer to normal. The past terminology, or some people like to call these rebalancing agents, if you think of coagulation cascade or the bleeding and clotting being on that teeter-totter that people sometimes show, you're kind of tipping the teeter-totter to the other way. I'm not sure I love that because I'm not sure what we're balancing, but I think it's another way to think about it. In this publication from Blood in 2024, this was looking at the reduction in bleeding using fitusiran in people with and without inhibitors, and you can see there was a significantly reduced annualized bleeding rate in those on the medication. So one of the things that came out with fitusiran was this 2017 press release where there was clotting associated with a fatal cerebral sinus venous thrombosis. And it was misdiagnosed. It was misdiagnosed as a subarachnoid hemorrhage and then went on to receive multiple doses of factor VIII. It was really a thrombotic event. So there was this pause, and what ended up happening when the company went back to do further testing on this medication is they developed an antithrombin-based dosing regimen. And so now the commercial product utilizes this and also utilizes a specific bleed management guideline that uses reduced dosing of factor products if you were to have a bleed. So this slide shows people before going into this dosing regimen and how low some of those antithrombin levels had gotten in their treatment. And then there was this pause, this black line here. And then with the antithrombin-based dosing regimen, looking for ranges between 15% and 35% of your antithrombin, you can see how much tighter control there is with that. And they found that the hemostasis was similar. Another medication targeting another part of the coagulation cascade is concizumab. And that is a monoclonal antibody-directed TFPI, apparently got dyslexic there, and inhibiting TFPI decreased the blood loss in a hemophilic mouse initially, subcutaneous administrations, and then again, hemophilia A and B and other factor deficiencies. So we decrease our TFPI and we increase our thrombin generation. So in the New England Journal of Medicine in 2023, Matsushita et al. Published the results of their phase 3 trial. And you can see here that when you look at the mean ABR, the annualized bleeding rate, there was a significant difference in those who are receiving the medication. And so that's going to be these two lines here compared to those who were not. Another TFPI inhibitor is marstacimab. Marstacimab, I can't say that one, but it is subcutaneous administration as well. Once weekly dosing and approved for prophylaxis in age 12 and up. Now, many of these medications are approved in age 12 and up, with the exception of imicizumab, which is approved for infants. And so for those who are FDA approved. And so when we're talking about research and treatment in children under the age of 12, we have to consider the studies and who they enrolled and whether or not it is appropriate for children versus adolescents and adults. This is a recently published review looking at the key safety features for marstacimab and the study phases that were there. And for the most part, it is excellent, shows excellent safety. You can see there's no thromboses and the adverse events are fairly straightforward. And so this is going to be another option for us moving forward to treat our patients. And the benefit of this medication in comparison to concizumab is that the concizumab is once daily dosing, and this is once weekly. There has been some work on inhibition of activated protein C, and it has been mostly in preclinical trials at this point. But the idea being, again, that if you have activated protein C inhibition, that will lead to further thrombin generation. And again, this whole thought process. Defects in protein C do lead to, which is factor V Leiden, which means your factor V is more constitutively activated. That can lead to clotting. We have seen evidence in clinical observations previously that people who have hemophilia and factor V Leiden may have less bleeding. And so that's what led to this consideration. And there is some preclinical trial that shows that with mouse tail clip, you can see that there's a decreased bleeding with different APC inhibitors. This is an older study. There are actually fairly more recent studies. This is actually visually shows it better than some of the others. They're all fairly similar and all still in that preclinical trial. And this is just another way of looking at this with improved bleeding when you use that. And this is just a summary of different preclinical trials of of drugs that are being developed for different bleeding disorders. And I'm using bleeding disorders broadly here because they rebalance or affect different portions of the coagulation cascade. It does give us the opportunity to consider usage of these medications in different populations. But I'm going to talk a little bit about where that can be a little concerning, or at least we'll have to deal with some of the problems that can arise from that. So just to run through these, there's another antibody that decreases antithrombin, and they found increased thrombin production. I kind of love that it's from the llama, but that's me. And then the DNA aptamer inhibition of activated protein C we talked about. and some activated protein C activity. And you can see all these different kind of ideas. And here's just another kind of, if you're more of a visual picture kind of person, different places in the coagulation cascade where we can target our approaches. And this is just kind of sums this up a little bit. So we have our coagulation cascade again. You can see where our factor VIII mimetics come in. There are TFPI inhibitors, and I haven't gone through all of these, are activated protein C inhibitors, and then are anti-RNAs, which actually works within the cell, leading to decreased antithrombin. The beauty of coagulation is that it's really complicated, and that leads us to all these opportunities. But it also leads to some unanswered questions. And so we already talked a little bit about the risk for thrombosis in some of these medications. Many of things have been mitigated through approaching the treatment of bleeding associated or while on these medications in a more delicate manner. So, when I was training, when Dr. Recht was training, it was treat first, ask questions later, and give as much as you think you need to, or even more. And I think we've really had to adapt our approach to clinical treatment of bleeds based upon the newer medications that are available to be a little bit more judicious with that. But what about if we use this in women on OCPs or who are pregnant? Are we going to have to worry about those thrombotic risk situations? Is it going to be different with a different bleeding disorder where we're in a different part of the coagulation cascade and they have a slightly different response to these changes that we're doing? There may be side effects not related to anticoagulation. Our coagulation proteins and anticoagulation proteins have effects other than coagulation within the body, primarily in immunity and inflammation, though also in some, responses to infection and things of that nature, or in case of factor VIII, bone health. And so we have to consider what non-replacement, instead of replacing that factor, the impact that'll have on those patients as life goes on. And what is an appropriate price for these kinds of medications? I think some of that has been worked out just because some have gone on the market at this point. But I do think that's something we're going to have to consider as we go forward. We already know that treatment of hemophilia is incredibly financially burdensome. And how can we make that more tolerable for families so that they can live their best life? And then what is going to be kind of a corollary to that is what is going to be the access in underserved and under-resourced countries? Are they going to be able to get those things? Now, in some ways, being able to do something sub-Q or oral might be easier in some of these countries, as long as they can pay for the drug. So in conclusion, the landscape of care for bleeding disorders is changing. I mean, it just is. I mean, and so we're going to have to figure out how to incorporate all of these and utilize them with or without our traditional therapies. New therapies are here and more are coming. And there are several unanswered questions in specific populations. And particularly, we're going to have to be creative in how we study these populations because these are ultra rare disorders in many cases. So how do we design trials that are inclusive and accurate, but also make sure that we are addressing the needs of our entire population instead of focusing on the larger portions? I really appreciate the opportunity to give this talk. I learned more than I like to do these things because I update my own knowledge, and I look forward to your questions. Thank you.
So I'd like to thank Lauren and Shannon for the talks. Sadina, I don't want to put you on the spot. What do you think?
Totally fine. I think they were great talks. I think it's a lot of information to absorb. But I guess if you're ready for me to go, I can just talk a little bit.
Yeah, we would
Don't
love
really have
to.
anything special planned. Just a quick bio. I am A mom, I'm a nurse, I'm very busy, so I didn't have time to put slides together. But my son, he is my only. His name is Blaze, and he is 10, and he has mild hemophilia A. And when he was born, we weren't aware that it ran in our family. We did eventually find out that I am a carrier. And looking back through our life history, my dad had it as well. Just he went undiagnosed, despite multiple severe bleeding episodes during his life. He ultimately was diagnosed at the end of his life when he was undergoing treatment for cancer. Um, However, my son was born, and on day one of life, he experienced a very profound, catastrophic intracerebral and subdural brain bleed. So we didn't know what caused it at that time, and they did all the workups, all the things, and they ruled out a bleeding disorder, actually, initially, because he did not bleed from his circumcision. He didn't show any other signs of bleeding. Um, Eventually, they determined that his bleed started during labor, probably from a short period of hypoxia, and he just couldn't clot it off. It probably started as subdural, which then progressed into an intracerebral. And it was a right frontal bleed, and it caused an ischemic stroke as well. It caused some herniation of his brainstem, a big midline shift. It was just a very profound stroke. So initially, it was, gosh, that was a whirlwind time. We weren't sure if he was going to survive. And then when we knew he would survive, we didn't know what his outlook would look like neurologically. And at that time, we were working on, he did not have a bleeding disorder. We were told at the time that his factor level was low normal. I want to say it was in the high 40s. And we were told at the time that because his factor level was more normal, and he didn't bleed from his circumcision, that he didn't have a bleeding disorder. So fast forward, fortunately, the hematologist we were following did insist on more blood work at 6 months. His PTT was still slightly elevated. So again, at 12 months, they did a full bleeding disorder panel. And then they did discover that his factor level was in the 20s. And ultimately, we did some genetic testing and things to confirm that it was hemophilia A, and that was what caused his brain bleed. And since then, we have been very lucky. We haven't had extensive bleeds. We've had some minor joint bleeds. He broke his arm, so we had a little bleed there. Nothing major has happened since that one, but that one was major enough for us. Um, and I look back and I wish I had had the knowledge that I have now, because as a nurse, critical care is my background. And I had been a nurse for 12 years in a large ICU in a large metropolitan area at the time. And I had never taken care of somebody with hemophilia. And I had only taken care of somebody with von Willebrand's twice. So for those in the hemophilia and bleeding disorder community, it may not feel like this is a rare disorder, because you see it all the time. But for those in the rest of the medical community, it is fairly rare, especially if you're not in pediatrics. So I really had to do a lot of research, and I had to brush up on some things. And even our adult hematologists that I worked with didn't know much about hemophilia, and most of them just said, it's primarily treated by pediatrics. So we kind of use it or lose it, and we don't use it. So fast forward again, my son did develop intractable epilepsy at the age of 2, caused by that stroke. And so while the epilepsy has been the definitive health problem in his life, the hemophilia is what caused all of it. Um, and so I have felt closer to the bleeding disorder community than I have the epilepsy community. I think because I'm passionate about uh, spreading that awareness and educating, because maybe had there been more knowledge, maybe my dad would have been diagnosed prior, and it wouldn't have been something we had to kind of wait and see on. But he is 10 years old, and he is thriving. We have had a lot of health issues, and sorry if I get choked up. I'm going to try not to. Um, he recently had a very large um, epilepsy surgery. So he had to have a right-sided functional hemispherotomy, and that was April 1st. And his seizures, while not frequent, they are only a few times a year, but they are all status epilepticus, and hours long, and they leave him in critical condition in the ICU. So ultimately, we decided that this was just our option. And so it was very scary during the hospital stay because he has hemophilia. And while, of course, we had this procedure done at a very well-known, very wonderful Tier 4 epilepsy center with amazing hematologists, it was scary for everybody. Hematology, neurosurgery, everybody was worried. No, they had not done this procedure on somebody with hemophilia before. He had had a prior surgery. He had a vagal nerve stimulator implanted. No bleeding with that. We did have to stay for 5 days, and that's usually an overnight stay for transfusions or infusions and lots of blood work. During that stay, he did develop an inhibitor. It was very mild. They only saw it, the pathologist saw it, but it didn't come up positive on any of the screenings that they did. But they did have to continue to give him additional factor in order to keep his levels within a normal range. So for the big surgery, hematology had to do a lot of, I think, a lot of research. I think they had to do a lot of legwork to figure out what the best plan was going to be for him. And they did a great job. We had no bleeding episodes at all, no bleeding issues. He had a drain in his head for about a week, and we had 0 issues. I really can't complain. It was just a very scary time. So looking back at my life, at my family's life, like I said, my dad did have pretty profound, or he had mild hemophilia, but he had a few profound bleeding episodes, one lasting as long as 2 weeks that he was hospitalized for as a teenager for, I believe that one was a tonsillectomy. So, and it just kind of baffles me as to how he went without being diagnosed, but I know so many things have changed. I never had big bleeding issues, but I did have heavy menstrual bleeding. I still do at times. I have had my factor level checked, but as I've gotten older, things have gotten different. I did have iron deficiency anemia as a child. I did bruise easily. And then I didn't for a long time. And now I'm starting to kind of bruise easily as I'm getting a tiny bit older. And so some of the information that was shared here does hit home a little bit for me. So we don't know if it goes further back than that because unfortunately in my family, everyone that we could look at is deceased. But my son has been very lucky. He's had great medical care. And I feel very blessed and grateful to have been asked to just kind of share our story and talk about what it's like to live with somebody with hemophilia. And while he is mild, and I did share this earlier when before this went live, that we have often felt out of place and bleeding disorder events because he is mild. He doesn't treat weekly, daily, monthly, but we have to keep factor on hand. We live in a rural community. None of the hospitals within a 45-minute drive carry factor. So we have to keep that on us in case of emergencies. Our lives are forever changed because of hemophilia. And so I really appreciate the opportunity and I welcome any questions that anybody has. And I think that's about it.
Thank you so much. Really appreciate that, Sedina, and also Dr. Carpenter and Dr. Amos. Really wonderful, telling us about these advances and some challenges about doing research focused on children and adolescents with inheritable bleeding disorders and the impact on the quality of life of our youngest community members and their families. So thank you so much. I do just want to draw our audience's attention before we move quickly to the Q&A, to the chat. You should find a chat feature at the bottom of your screen. I've dropped a couple of links in there while our presenters were speaking. There's some resources there around the coagulation cascade and how some specific treatments work. And then also we have a link to the Facebook page of Sedina's son, if you want to check that out. That's a great profile that you can check out there. And for those of you who are with us on the LinkedIn and Facebook events, I've put those links into the comments of those events as well. So I think we'll go ahead with our Q&A now. And we've only got a couple of minutes, and I would like to throw maybe quite a big question out, but I would love to hear from each of you on it. Why is it important to do research in children and adolescents with inheritable bleeding disorders? Why can't we just extrapolate from adults? Why do we need to do this?
Oh, pediatricians love this question. Children metabolize medications differently. I think it's the short and sweet answer for that, for one thing. And so in many cases, we find that they need a different dose, or they don't, things don't work quite the way we thought they were going to. I think beyond that, too, children are growing and changing. And so the impact of medications on growth and, in the case of hemophilia, joint health and bone growth is really important too. So those are my two answers. I'm sure I could go on, but I'm going to let my co-panelist answer some of this.
Yes, I mean that the classic pediatrician phrase is that children are not just little adults, and I think if you think about specifically the female population, so adolescent and young adults in terms of reproductive health and needs are it's very different than adult women, and hormones play a very big role in menstrual bleeding, and there's a significant amount of hormonal changes that happen with that growth and development that Dr. Carpenter mentioned as well. And so it's just a unique population. It's the same reason that you can't say that, women and men should have, if a trial's done on a man, then then we don't need to do it and include women or that kind of thing, because every population is unique and needs specific studies that focus on that.
So Dina, can I ask you, based on what you've heard and then based on your son's and your entire family's medical journey, any reflections on the importance of research in kids? And just before you answer, I'm lucky enough to be able to extend Shannon's and Lauren's children aren't just little adults. And then I can say, but at 5'5", I am a little adult. So So
Oh,
that's
well,
different. So
at 5'2", I guess I am too. Um, from a parent's point of view, I mean, children are different. And if we do the research on children, um, I think we're going to get better treatment for children. And if we get better treatment for children, then that means better longevity, better health, and possible prevention in comorbidities down the road. And as a parent, I just want my child to be as healthy as long as he can and to be diagnosed and to have treatment options as early as possible. If you don't include children in that, it's, I just think it's important.
Dr. Rector, is there anything that you wanted to add to that?
no, I think it's really well covered. I think Lauren hit the nail right on the head when she talked about not only our kids, not just little adults, but people born female, people born male are different also. So we have to include all of our community in the opportunity to be involved in research.
I think that we've really come to the end of our hour very quickly. And I think the one thing that's very clear is that we need more of these webinars and more of these discussions because we've got so much more to say. And I'm so sorry not to be able to answer everybody's question today. But I really do want to thank Sadina Hartley, Dr. Lauren Amos, Dr. Shannon Carpenter for sharing your time and your expertise with us this afternoon. A huge thank you also to everybody attending today. We really appreciate you being there. And to HTRS for partnering with NBDF to bring us this series of Journal Club webinars. This recorded webinar will be available shortly on bleeding.org under the events tab. If you pick the past events, then you can see all of our archived webinars there. And you'll also see the upcoming webinars. Please join us again next week for a Sanofi-sponsored webinar in which Dr. Akshat Jain from Loma Linda University and Children's Hospital will tell us about a new rebalancing therapy delivered by subcutaneous injection for hemophilia A and B. Thank you so much for joining us today. Have an excellent week.
Thank you, everybody. Thank you, Fiona. That was excellent. Thank you, Shannon, and